All right, so I'm James Harvey. I'm an interventional cardiologist. I also serve as the Chief Medical Officer for the WellSpan Health System Heart and Vascular Service Line. It's a privilege to talk about a standardized invasive hemodynamics to facilitate lifetime patient management. So these are my disclosures. I'm going to start with a question on everybody's mind. Why are we doing this at 6:30? I don't have the answer to that, but it's a very good question. So let's talk about TAVI and the importance of hemodynamics. So hemodynamics. So I'm not going to get into the debate of the observed. We know there's discrepancies between echodoppler and invasive. Now, if you want to talk about pressure recovery, this has been a fairly age-old debate that if you looked at the late breakers, et cetera, that wasn't resolved at this conference. So, but we do know that there's observed discrepancies, and I think few would argue that the gold standard is invasive measurements. That being said, they take time to set up. You need wire and pigtail exchanges. LV pressure is not monitored constantly during the procedure. Have we proven we can do that? The answer is yes. Would it be ideal to have it? The answer is yes. Large amplitude LV pressure creates artifact in fluid-filled tubes. Is this true? It is. Is it true all the time? No. Does it impact some of our cases? The answer is yes. But is it always there? No. We know that assessing and treating moderate aortic stenosis looks more and more like it's going to become important in the future. And I would argue the most important one is we're treating lower risk, aka younger patients. They're being treated, which means that good enough is not good enough anymore. We have to be great. I don't know if you remember the movie The Princess Bride. I've been lucky enough to say I started doing TAVRs about 12 years ago, 13 years ago, and the character in The Princess Bride said, he's not dead, he's mostly dead, right? And that was kind of like the patient subset, get him out alive, because really we had a really sick patient population, but our patients are now lasting 1, 2, 3 decades after TAVR. Good enough is not good enough. So what about the SavvyWire? What about hemodynamics and workflow? You can see here, and I won't belabor this, but we have the optomonitor interface with an optical connector that can be connected or disconnected anytime. If you use the OptoWire 3, it's very similar. Hemodynamic pressures, gradients are always available without exchange at baseline, after pre-dill, during partial deployment, if that's what you want to check during self-expanding valves, post-dilatation, and at the end. You have accurate live diagnosis the entire time, gradients, whether you want mean, peak to peak, max. If you want to assess aortic regurgitation, most of us are good at looking at the AO, the diastolic pressure, and the LVDP, and you can tell right then whether or not that you have significant aortic insufficiency instantly. So the display is actually, as you can see, quite favorable, and you have whatever setups you prefer as an operator, whether you're looking at, one of several LVEDP modes versus looking at systolic, diastolic. Again, you can see that you can get whichever instant recording or instant monitoring of peak to peak, mean, whatever it is that you need to use there at the time or that you prefer. So again, saying the same thing, immediate pre and post comparison without device exchanges. So he's covered that. So what do we know about it? Well, I don't think anybody would argue that invasive hemodynamics, like we said, are the gold standard. But you still want to compare this, right? And so actually, Philippe Généreux and his team did a nice study looking at comparing OptoWire 3 and our TAVR algorithm, comparing pigtail measurements, right? And what did we find? Well, not surprising, if you compare the OptoWire or the SavvyWire versus catheter versus what we consider the gold standard, whether you look at TTE, TE, any other comparison, there is no comparison better. There's no better correlation than options than LV pressure wire and cath. And I would actually argue that we're going to have to question, so is cath truly the gold standard? I think actually most of us, if you understand the physics behind it, would argue that this pressure wire is actually the gold standard. But either way, since we've historically used cath as the gold standard, I think we can at least agree that there's no greater technology that we have to assess that correlates better to cath than using a SavvyWire or this pressure-sensitive monitor. So similarly, if you look, when you compare the two in invasive gradients, I won't belabor it, but just simply looking at, on average, you have a 1 to 2 millimeter difference in mean gradient. Which one's right? That's a good question. I would argue that the wire is, but either way, I think we would agree, again, that we've shown that they're essentially interchangeable. So I'm an interventionist. I like showing cases. There are a couple of places that we found this to be, particularly the hemodynamics, the hemodynamic monitoring that I found is to be very valuable. This is a patient that we felt was appropriate for a balloon expandable valve. They were right on the cusp between a 23 and a 26. For a couple of reasons I won't go into, we felt a little more comfortable using a 23. And it's not often, but I've had times that I'll put in the lower of the valves and I'll find out, is this really right? Is this where I want to, or do I need to post-dill this? I really want to get the right hemodynamics here because you sure hate to see that gradient at 22 the next day when you check on your surface echo. So You can just see there, nothing special about the three-cusp coplanar view. You can see there, even with the wire in, I actually prefer oftentimes to fill it while pacing, just because you get a little bit better filling. You can see that with the wire in. So just assessing there, and I will comment that I think I'm one of the last holdouts to LV pacing. I did just great with an RV pacer. I didn't like it, didn't believe it, didn't need it. And then this wire came out after using it for not too long. We realized that not only was it dependable, it was more dependable. So you can see here, obviously, anyone who's ever been in a balloon expandable valve knows that that's the one part that can really get you is if you lose capture. And this is actually proven now to have the best lack of capture loss. So just looking here, and you can see how in real time we can keep it, you have the ground on the back, and we can have a real-time pressure monitoring the entire time. This is actually our setup right here. And this was that case. This was one of the first times we'd used this, actually. You can see here that we could tell very clearly that the 23 valve was perfect. We didn't need to add anything. And this is actually real time also looking on the side here. That I didn't zero it before, so I pulled back with the wire still in the LV, but the sensor across, zeroed it, went right back in. That's real time. That's exactly how much time it took. And the nice thing is, let's say that the gradient was there. They said, you know what, we really didn't do this patient a service yet. We need to post-dilate. I could add a CC right there on the table without pulling in the catheter setup. Is it the end of the world to have to do it? No. But as we move more and more towards value-based care, which actually is happening, if we're looking to improve our efficiencies, it really does make a difference. At least we've shown it in our lab. So one thing, I will say this, people who've done LV pacing a lot longer than I have, the common problem we have is what's the best way to ground the wire? I know we're coming up with more ways. I will just tell you this, that I would love to say I came up with it, but one of our surgeons said this is something they've been using hot off the press for about 50 years when you do cardiac surgery. Going in, what they do is they put this hook through the muscle. There's a wire with insulation around it with a little bit of braiding right there at the end. And so all you do, this is actually me, I put the suture through, I pull it through, I pull through till the braided part where the exposed wire is, and then I pull it back like that. You're grounded now. You're good for the case. We found that to be completely reliable, and you don't stick your hand inadvertently when you forget you have a needle in there. So this is just another case. This was a person who you can see, I won't belabor the hemos, but you can see they're pretty well compensated, has legitimate aortic stenosis, normal cardiac output, coronaries are nothing to write home about. But the patient had a BSA of 2.2 and a perimeter of 77. And so we were worried a little bit about the possibility of having some degree of patient prosthesis mismatch or something like that. And also you can see one other thing. This is a patient that when you normally look at this view, you don't see the extra cusp down here. So you can see the three-cusp coplanar was LEO 41, caudal 8. That's not exactly normal. Not the end of the world, but not normal. If you endorse the cusp overlap view, which we do strongly for deploying a self-expanding valve, you can see that this is not the normal view. What does it mean? You're going to need a wire that not just does what we talked about, but also can give you the support in a safe way. I think nobody would shy away from this access, but again, just showing that we've got some tortuosity. We're planning on using an Evolute system, and so we're going to need a wire that can accommodate this and do what I talked about. And so when we typically will look at our own measurements, we usually will use industry measurements as kind of an internal check. And we thought that based on our concerns, we thought this was most appropriate for self-expanding platform. The plan was to do a pre-dill, use a SavvyWire, and do an Evolute 29. And so again, we do pace during deployment. You can see here that obviously good capture using this, no issue with the wire. You can see the pressure sensor there. This is our cusp overlap view. We're deploying the valve, and this is the isolated non, just deploying up. No difficulty at all traversing the tortuosity I showed you, nor with this angle. The wire offered excellent support for that. You confirm the non, we're about 2 there. Flip it over to the left. We confirm the left, which if you really look at where it inserts is probably about 4. So 2 on the non, 4 on the left. We're very happy to drop this off. And we did, and right there at the time, we actually had a group of people watching while we did this case, and we said, hey, look at that. You see some ectopy here. That was actually the snapshot. I know what you're thinking. Wow, is that done from an iPhone? Yeah, of course it is. This is a real case we did, so yes. But you can see here, this was real time in our lab. You can see what the gradient was. You can see there's no gradient, which we didn't expect. And if you actually follow this out, you could immediately see there was no significant aortic insufficiency, but the group said, you know what, we'd really like you to prove that. We're not familiar with this wire right now. So we did, and By Seller's criteria, I would say that not one drop of dye went across the valve, so we were very happy with this result. But we already knew it when we looked at the hemodynamics right there. I'm getting kicked out here, I think. So the point of that was to say that not only were we so confident in the wire, but we were so confident that we actually did this for a live case for CRT. That just tells you that in a relatively short period of time, how comfortable we've become using this wire and how comfortable our labs have become as a workflow. So in conclusion, I can tell you that SavvyWire with hemodynamic measurements gives continuous, accurate measurement and display of hemodynamic pressure. It delivers the gold standard of pressure measurement, and it minimizes exchanges. I can also tell you that, in the era of getting faster, of getting more efficient, I can tell you that with a wire that really kind of like the Goldilocks story, the Safari wire we historically have loved. It sometimes is a little too soft. The Lunderquist is a little too tight, a little too stiff. This one's just right, if you will, with a very safe wire curve on it, and something that I was completely sold the first time I said, we're going to use the Savvy on this case, and my lab team went, yes. I couldn't believe it, but the actual efficiencies you get in addition to the hemodynamics really make a difference. So with that, happy to answer questions, and thank you very much.